Hi, this is Dr. Bassam Rabia from Cairo, Egypt. It gives me a great pleasure to be on Dental XP again after almost a year now. This is maybe my third or fourth lecture and video on Dental XP. Before I start, I would really like to thank and congratulate Dental XP and the Salama brothers for the wonderful meeting in Las Vegas last month, which I really had the pleasure to attend and meet a lot of friends from all over the world and share back and forth the knowledge and science up to date. This video is actually a continuation of the last case I showed on Dental XP, showing the surgical and prosthetic reconstruction of a compromised case of the anterior maxilla. Just to go and refresh the case itself, this is how the patient presented. As you can see, she had only an upper central incisor, the left central incisor, and a missing upper right one. And you can see the position of this central is not in the proper position. When we look intraorally, bad oral hygiene, a really compromised situation from an inclination of the anterior incisors and the lower incisors as well. And when we look at the soft tissue biotype, somehow we have good keratinized tissue around 3 to 4 millimeters beyond the cervical portions of the remaining teeth. And it was planned, according to the diagnostic wax-ups, to remove the remaining central and put some implants in this place, as well as the lower incisors were planned to be removed and placing implants to correct these labial inclinations of the upper and lower anterior teeth. If we look at the CT scans, we look at the labiopalatal dimensions of these premaxillas, where the upper left central incisor is. Somehow we have good bone, not enough to place implants without bone, but it can be placed with bone. But when you look at it, if we place the implants in this bony housing, we would actually find that we are placing the implants in the same labial inclination, and thereby we're not really solving anything. But when we look at the 3D rendering from the Simplant software, a virtual planning of placing the implants according to the wax-up, according to the proper occlusion, you can see that the whole body of the implants are actually out of the bony housings. So let's just take the case from the surgical step, which I already showed on Dental XP with a video, but these are just slides just to refresh, as we said. Here is after opening the flap, removing the upper left central incisor. We look at the amount of bone labiopalatal. We have around 4 to 5 millimeters, but you can see the concavities on the labial aspect of this premaxilla. After root canaling the laterals and reducing it as it was planned after extracting the tooth and doing the surgical step, which I'll show right now, is to place a 4-unit CAD-CAM temporary bridge. From the preliminary wax-up, a simple surgical stent is constructed, not to place implants, but just to show you that if I'm passing the pilot drill of the implant that is proposed or anticipated to be placed later on through the palatal aspect of this stent, it is actually out of the bone aspect. So in this case, the choice was to augment this premaxilla, and in this case I decided to use bone blocks. But instead of taking bone blocks from the patient herself, I decided to use the allografts, the allogenic bone blocks, which in this case is the Mineros bone blocks from BioHorizons. And it is a corticocancellous type of bone block. After just contouring the block to fit in the size, the first thing we do is actually preparing the receptor side, the bed in this area. And as Maurice Salamauser says, we have to penetrate and prepare the bed for intramarrow penetration of mesenchymal cells. And you can see the amount of blood that is actually absorbed into the cancellous part of this block. And from the outer side is the cortical part, which is also important for fixation and for slow turnover of this piece of block. 2-point fixation, as Dr. Picos always says, for proper fixation and no micro movements. On the left side, it was just one fixation screw that I needed. As you can see, the nasal spine that is going down is actually prohibiting the piece of block from moving mesially or distally. And after contouring, after fixation, proper contouring of any sharp margins, and as you can see, the gaps in between the blocks and the native bone should be filled with bone graft particulate, which again was the Mineros allograft. And you can see it's covered with a Memlock collagen membrane, again from BioHorizons, overlapping the labial aspect and overlapping with another collagen membrane from the labial crestal and tucked into the palatal flap from inside. And then this is just from the CEREC machine, which I happen to have in my office. The Sirona CEREC machine, the CAD-CAM, just the preliminary planning of the temporary bridge, which was during the surgery being milled in the machine. So after the surgery, we can just place the temporary bridge. This is after 2 weeks of healing. After 2 or 3 weeks of healing, crestally, you can see everything is closed. It's very important that these blocks are not exposed. And of course, this is when you have somehow good type of biotype of the soft tissue itself. And then cementation of the temporary bridge. This is actually, the slide is maybe after 2 months of healing. You can see the amount of some kind of recession around the roots of the laterals. After 6 months, still everything is fine. Occlusally, incisally, labially, everything is okay. And then from the cone beam CT, after 6 or 7 months, just checking the bone blocks in place with the fixation screws. This is the upper right part, if you remember, was the 2-point fixation screws. And you can see the amount of bone that we have achieved from a labiopalatal perspective. These fixation screws, again, these were from the fixation screws of BioHorizons. They were around 9 millimeters in length. So we are talking around 8 to 9 millimeters of a buccopalatal dimension of bone in this area. Now, after almost 8 months, which I always like to leave with these types of bone blocks, these allograft bone blocks, it's time for the second stage, in this case, where we open and place our implants. From the software of the Sirona cone beam, just a short explanation. There is the panoramic view. You can see the fixation screws. And then when we take the 3D rendering of this software, looking around just to give an idea of the fixation screws and the block grafts and the amount of bone that has been achieved in this area, then taking a cross-sectional cut in each of the blocks so we can properly measure the amount of bone that has been achieved buccolingually. Again, as I said before, almost 8 to 9 millimeters on the right side as well as the left side itself. You can see the amount of bone that has been achieved. Everything is fine in place. And if we move a little bit across, the good thing is with the optical impression from the CEREC machine, we can actually construct or virtually plan the 4-unit anticipated bridge or restoration, and we can actually overlap this optical impression on the cone beam CT by matching these 4 points, by actually placing points on each tooth which resembles on the optical impression on the CT itself. And then you can even show from this 3D rendering, as you can see here, where exactly the teeth are gonna be. It gives you an idea if we enlarge and magnify one of the cross-sectional cuts at the block grafts. All this is before placing the implants itself. It gives you an idea where the tooth or the prosthetic or the final crown should be on the implant that will be placed. And as you can see, it's according to occlusion. Forget about the lower, because these lowers are planned to be extracted, and placing implants to re-angulate the proper labial inclination more into a lingual inclination. Again, from the software itself, we can actually take a cross section and we can see the soft tissue where it is. The software already anticipates where the soft tissue is in relation to the crest of the ridge. And from the library of this software we can actually choose our implant system that we're using, the type of implant, the diameter, the length of the implant that we can place according to the available bone structure in this area, and start placing it bodily according to my anticipated prosthetic definitive restoration, as you can see, and start aligning and angulating my long axis of my implant in relation to the anticipated final restoration. Now, coming to the surgery of the second stage, opening of the flap to expose the block grafts and remove the fixation screws. Of course, always using microsurgical instruments and handling the soft tissue and the hard tissue very meticulously, using a micro periostal elevator, slowly elevating a full thickness labial flap. You can see the bone blocks in place, attached, fixed, and with a bone gauge you can see that we're measuring actually the amount of bone available, which read around 7 to 8 millimeters. Now, removing these fixation screws are quite easy, unscrewing them and just with a gauge measuring the vertical dimension. And now with a milled CAD/CAM surgical stent, just to show where exactly my implant should be in relation to this anticipated milled stent, placing 2 bi-horizons internal tapered laser locks, which should be parallel to each other, and as shown here, trying to respect the distances mesodistally between both implants and in relation to the neighboring natural teeth. Usually I like to place my implants manually so I can actually feel the quality of the bone. In this case, the quality of the bone was quite good in these block grafts, and they were very well consolidated in this area. And due to the fact of the difference of levels of the bone blocks in this area, since I'm using a laser lock implant, which has been proven scientifically that it has physical epithelial connective tissue attachment to these microchannels on the heads of the implants, I'm not really worried about recession in this area. Although according to a Cochrane systemic study from Marco Esposito, it has been shown that there will be some kind of vertical resorption of these types of bone augmentation procedures. Furthermore, to augment the soft tissue and thicken this soft tissue, which was known that sickening the soft tissue is actually the best way of stabilizing the amount of labial bone in front of the implants using acellular dermal matrix, which again from BioHorizons, the alloderm, which was soaked first for 10 to 15 minutes in a warm saline bath, and then suturing properly and placing the temporary bridge. After 1 week of healing, after placing of the implants, everything looks fine. Again, just a short video of the cone beam CT after placing the implants. As you can see, the placement of the implants according to the stent itself. If we move further faster and taking a cross section of the implant itself, you can see the amount of bone labial to the implant, which is around 1.5 to 2 millimeters, which we need in this area. And as we said before, that we have the laser lock microchannels, which in this case doesn't worry me from any kind of soft tissue recession in this area. If we move further, there's the software rendering, and again just placing the anticipated optical virtual planning from the CEREC machine onto the cone beam, just to show exactly according to the surgical guide that guided where the implant should be according to the long axis and according to the future anticipated definitive restoration itself. Again, just cross sections of the cone beam showing the amount of bone from a labiopalatal aspect. Now under surgical microscope, just showing the third stage of opening on the implants after integration in these block grafts. You can see the laser lock microchannels on these BioHorizon implants, which, as I said before, you might have some resorption, but at the same time, since we know there will be physical reattachment or physical attachment of epithelial connective tissue cells or fibers on these implants, again, not worried about really too much recession or too much resorption of the bone in this area. Now, according to placing the healing abutments, and of course the technique from Patrick Palacci from France, using the rotating pedicle soft tissue flaps just to give or thicken or give keratinized tissues in between the implants and in between the natural teeth and the implants itself, using microsurgical blades and rotating without tension these good keratinized amount of soft tissue in between the implants and suturing in this area very well. As you can see, the suture was a vertical mattress sling suture to keep these pedicle tissues intact until they are healed completely between the implants and the natural teeth. Of course, as I said before, I have to thank Devimet for supplying me with a kit which I chose with them that really helps in soft and hard tissue manipulation or management in implant dentistry. Now, after almost 4 weeks of healing and removal of the sutures, you can see the amount of keratinized tissue labial and in between the implants and in between the natural tooth and the implant itself. You might find on the left side of your screen the implant, there is some kind of recession a little bit, maybe 0.5 millimeters, but not to the level of the microchannels of the laser lock. And placing the abutments, the prepared abutments, and placing a CAD-CAM temporary crowns splinted together just for healing. And you can see how we started with this case and how we ended with this case. Was somehow this patient was happy to what we have reached with her. And again, just showing after several months of restoration, that's how we started. and this is how we ended with it. And you can see the soft tissue around the crowns, which are stable due to the fact that we have good thickness of soft tissue in this labial aspect, which is overlying the good amount of bone from the block grafts in front of our implants. And with this, I would really like to thank you, and waiting for another lecture in the future on Dental XP. Thank you very much.